Good morning, everyone. I would like to call upon the stage chairperson, Dr. Premchand Malpani and Dr. Pratik Parma. I would like to call upon stage Dr. Anand Raju to give his lecture on how to interpret DISE to improve your results.
Good morning. I'm Dr. Anand Raju from Tamil Nadu, the city from Coimbatore. Yes. So, welcome you all. First of all, I convey my sincere gratitude to Aziz Boomkar, so as well as Dr. Prasad, for inviting me to this wonderful conference, Maharashtra State Conference. Sorry, so we have our national conference in Chennai, that's why the last day visit, me and Atul for Nilesh. So, you know, DISE, so it's an investigation of choice for sleep surgery. So, we all sleep surgeons, we are doing routinely DISE. So, this is a small lecture, what is DISE, how we interpret DISE in our sleep surgery practice. Today agenda is actually what is DISE, where and when to perform DISE, and how to prepare for DISE, the drugs for sedation and maneuver and position, and how to interpret DISE in our surgical practice, and indication and contraindication, and what are the tips and pitfalls for DISE. So you know that actually OSA is a global problem now. So more than health problem, is a social problem nowadays. Actually, a lot of guys are coming after the marriage, coming for surgery as well as coming for consultation for snoring. So this is a 100% compliance, new technologies such as transvaal robotic surgery, coblation, all these technicals are available for surgical correction of upper airway. So we have pharmacological therapy in case of central sleep apnea or selective serotonin and reuptake inhibitors. All this actually is a new concept of pharmacological therapy, but it's all depends upon the individual selection. Conservative and non-surgical managements or weight loss, alcohol avoidance and sleeping on one side and myofunctional therapy, all these are conservative non-surgical things. And then nasal CPAP or maybe oral and nasal CPAP all together. So we can manage the patient of OSA. So this small video used to play in all. Sorry for the delay. It's a small video I used to play in all my presentation. How it is a big social problem. So she is finding solution for sleep apnea. So she is trying various options, closing the nostril. So now this is a global burden now actually. So there is a new technique she found finally to arrest the sleep apnea. But so there is a failure. So that's why we need to know so exact level of obstruction and what is the cause for obstruction and so what is the solution for obstruction. That's why this drug-induced sleep endoscopy plays an important role in sleep surgery. So what is drug-induced sleep endoscopy? You know that. So we are giving a drug and make the patient to sleep, and we do an endoscopy faster than nasopharynx, nose, nasopharynx and soft palate, and assess the whole area, the level of obstruction. So it mimics normal sleep, but is not a normal sleep actually. So why do we need a DISE actually? So we need DISE actually, but we can find in outpatient clinic, we can examine the patient, we can find the nasal obstruction and turbinate hypertrophy, huge tonsil, sometimes even bulky tongue. But actually we don't know how these physiological structures, anatomical structures are behaving in normal sleep actually. That's why we need to make the patient sleep and do an endoscopy. Then we can find the pattern of collapse as well as the severity of collapse and the level of collapse. That's why we need a DISE to improve the results in sleep surgery. So in small percentage of OSA patient, anatomical cause obstruction are obvious. Actually, we can straight away find the deviated septum and grade 4 tonsil, lingual tonsil. But most of the patient, the cause is not so obvious. But all these physiological anatomical structures, they behave differently during sleep. So they may have a long soft palate a relatively large tongue with a grade 1 tonsil, or maybe they underwent previous tonsillectomy. So these are the patients, they are coming for a severe OSA. This type of patient, we definitely have to find the level of obstruction. What is the cause for obstruction? Sometimes maybe it's central sleep apnea, or maybe a severe level 3 collapse. So we need to find the level of collapse and the pattern of collapse. That's why DISE is very important in our routine sleep surgery practice. The origin of DISE actually, so the DISE in the late 1970, evaluation of airway during natural sleep was proposed. A lot of surgeons actually, they pass a normal bronchoscope, a thin bronchoscope into the nose and keep it above the soft palate. They observe throughout the night, but it's very difficult to keep the scope inside the nose and sleep during routine normal life actually. So they failed actually to find out the exact obstruction, the pattern of collapse. So sedation to induce sleep was introduced in 1990 by Kraft and Fringel. They actually somehow succeed to assess the sleep obstruction during sleep. The sedation airway could be observed dynamically. This allowed to sleep surgeon to have an accurate idea of what is happening during sleep and the possible treatment option. Somehow actually they are not able to achieve to give a proper sedation. So then actually key findings of DISE so already I discussed, so we need to find the level of obstruction. The level of obstruction is not enough, the severity of obstruction and pattern of collapse, whether it's anteroposterior or maybe circular or only lateral collapse. So the Starling resistor model is this important thing we have to know. So morning we discussed actually with our Asim boy, actually the nasal resistance is one of the very important thing. So we have to keep it in our mind actually. Whenever the nasal resistance is severe, so definitely there's a model is actually nose and trachea is a static pipe actually, it's a rigid tube actually. Only the pharynx is a collapsible tube. Whenever the nasal resistance is high, the mid portions definitely will collapse. So we have to improve our nasal resistance, then only the airway will improve. This is the Starling resistor model. So we always keep it in our mind during our practice actually. So we are dealing with the two type of obstruction. One is static obstruction, the another one is a dynamic obstruction. Static is deviated septum, adenoid and turbinate. Dynamic, nasopharynx, actually normally we used to miss salpingopharyngeal fold, soft palate, tonsil, tongue base, epiglottis, sometimes even larynx also. Yeah. So there are too many options actually. How do you know which option to choose from without knowing so what will work? So before going into the details, so we need to know the sleep cycle. There are 4 stages of sleep, stage 1, stage 2, and stage 3, and stage 4. The stage 4 REM sleep, normally we won't mimic stage 4 sleep in our routine DISE actually. So it's very difficult to mimic in REM sleep, but a lot of collapse occurs in stage 4 sleep only. So that's why DISE is also now actually there is a question whether really we need to do a DISE or straight away we proceed. Stage 1 is light sleep. So your brain and heart rate and breathing slow. Stage 2 is a light sleep, it's around for 1 hour. Deeper sleep, your body start to relax and body temperature drops. And stage 3 is the deepest stage, it's a non-REM sleep. All this non-REM sleep, your body stays very still and your brain waves slow down. So interpretation of DISE actually, so what we are doing in a stage 3 sleep. Stage 4 is a rapid eye movement, it's a dreaming stage. So it's very difficult to achieve this stage 4 sleep. Sometime in midazolam we can get a stage 4, but it's very dangerous to make the stage 4 sleep. Most of the symptoms in obstructive sleep apnea and hypopnea syndrome in adults are related to the stage 3 NRM sleep. In REM sleep, hypotonia upper airway muscles increase the risk of upper airway obstruction. REM-related OSA is always mild arousal index, milder effect on oxygen saturation. Sedation in DISE mimic non-REM sleep, so we can't stimulate REM sleep in DISE. Then part 2, so when and where to perform DISE. So normally we do DISE in the operating room. So there's a lot of actually nowadays, a lot of consultation is, we post the case for DISE first, then we will discuss with the patient attender as well as the patient with the video. Then we will take the case for surgery, the next stage. But at least 6 months before, we used to perform DISE just before the surgery, and we'll discuss with the partner and straight away we'll proceed. But DISE should be performed in a room where all the basic resuscitation equipment must be available readily actually. Sometimes the collapse is very severe, we go to intubate immediately. So suppose, no anesthesia, the anesthetist must be standby. So if there is no anesthesia instrument, definitely sometime we will lose the patient, sometime we have to do an immediate tracheostomy also. Room should be also be quiet and dark. The patient must be monitored throughout your DISE. Thinnest and possible fiber endoscopes. We need to have a small thinnest endoscope, is around 2.4 or 2.5. So recording system for video and sound must be there to record this thing. So sometimes we used to miss, so we even with the record actually we can assess very clearly so the pattern of collapse. And we have to discuss with the video with the attender as well as the patient. So what are the procedure we are going to perform? So it's a staging system or single stage. All we go to discuss before surgery with the patient or maybe with the attender. The evaluation of the upper airway in lighter sedation may underestimate the obstruction. So we need to do a DISE at least for more than half an hour. So a lot of actually surgeons, we do a DISE just for 10 minutes because our anesthesia pressure is more. So suppose the sedation saturation goes down below 6 actually, so they used to pose us to, I want to intubate actually. So, but don't actually do it. So wait for at least 10 to 20 minutes to do a DISE properly. So deeper sedation may cause artificial obstruction due to over sedation. Suppose you give a over sedation, it produces over collapse. That is also important. So sedation level observed with these devices are on estimated actual sedation. So that's why BIS level monitor is very important. So suppose you want to practice proper sleep surgery, so definitely you need a BIS monitor. BIS monitor is the one we can assess the sedation of the brain. So normal level is 70 and 50 and the upper airway is evaluated in adults. Actually this is a normal sedation. So what we need to perform a DISE. So for some people are not well sedated at those recommended level. For children these BIS levels might not be applicable. So BIS monitoring is one very important actually, so it's very costly, but it's only available in a corporate setup. But suppose you want to do only sleep surgery, so want to do a proper sleep surgery, definitely you need a BIS monitor. This is an overview of drugs-induced sleep endoscopy. So we need to stimulate natural sleep. We need to have a flexible endoscope and sedation with the propofol. So a lot of drugs are there. So normally what we do is propofol stimulation, assessment of airway collapse. So this is the overview of DISE actually. What we are doing is all these 4 steps. And we're coming to the part 3, so how to prepare for DISE actually. So these are the drugs routinely used for drug-induced sleep endoscopy. So propofol, midazolam, dexmet actually. The dexmet is the one nowadays we are routinely using along with the propofol. So the propofol is actually, its functional half-life is 4 to 6 minutes. Midazolam is 45 minutes. Dexmet is only 6 minutes. Estimated half-life is 3 hours, 150 minutes and 2 hours. So accumulation, inactive metabolite, there is no accumulation for propofol. Active metabolite is accumulation is there, inactive metabolite, no accumulation. So this is dexmet and propofol are very good agents for drug-induced sleep endoscopy. So this therapeutic range is very small. So midazolam, suppose the sedation is very high, so it's very dangerous also. Suppose you give a overdose, it's very dangerous. So dexmet is very small. Normally what we do is we start dexmet in the preoperative room itself. So it's a small infusion. Then we will shift the patient in mild sedation into the room and then we will give a incremental dose with the propofol to stimulate the sleep. When the patient starts to know, then we have to do a DISE. A lot of doctors straight away, when the patient is normal sleep, actually they do this thing, but we can't find out the pattern of the collapse. So cardiovascular complications are very less with dexmet. So little bit hypotension and propofol also produce hypotension, but easily reversible. This is the reversal is take a longer time. So although a standard DISE sedation protocol is not available, propofol, dexmedetomidine are the drugs commonly used in DISE. Other drugs such as midazolam, ketamine, remfentanil can be used as adjuvants actually. Sometimes the patient, they can't sleep with even propofol and dexmet. At that time we can give a little bit incremental dose with the midazolam and fentanyl. So dexmet is the selective alpha-2 receptor agonist which acts on the locus coeruleus of the brain. It stimulates normal sleep, almost it mimic normal sleep. That's why dexmet is one of the wonderful drugs. for a drug-induced sleep endoscopy. So we can give a fentanyl, midazolam, and we can give a propofol, like incremental dose. Suppose the patient so easily come out with a sleep, then we can give a propofol to, so it's like adding dose. So we have to do some maneuver during our drug-induced sleep endoscopy. Just doing a routine sleep endoscopy in supine position is not advisable. Usually observed in supine position. Sometimes we have to rotate the patient itself and assess the positional DISE actually. So positional DISE sometimes give a clear idea about, sometimes we advise a positional therapy to the patient, they can improve with sleep apnea. So the SMAC procedure, you know that grabbing the mandible of the patient to mimic action of mandibular advancement devices, just pull the mandible up so we can assess the improvement of the airway. Jaw thrust maneuver can be performed. Changes to the area and pattern obstruction can be observed, just closing the mouth actually. Just close the mouth and do the endoscopy, just pull the mandible up, then we can assess the improvement of airway during sleep apnea. Just small video. So it's labored breathing. It's not a very obese. The BMI is around 25 to 28. I think no sound in this actually. This already sound is there, but it's not coming. So we assess the collapse of the lateral pharyngeal wall and the epiglottis. See the epiglottis is a little bit floppy and it causing collapse. The patient has a tonsil also. It's a little bit lymphoid hypertrophy at the tongue base. Epiglottis itself falling back and causing collapse in the airway. See? So we have to wait for at least more than 10 to 20 minutes to assess the upper airway properly. And giving a jaw thrust, it's improving the airway. See, now the anteroposterior collapse is gone, only there is a little bit lateral collapse. This patient may improve with the mandibular advancement devices, but the compliance is very low. So we have to counsel the patient so we can advise them. But in this patient, so in this age, so mandibular advancement devices during night may help actually. But we can discuss with the patient all various options. The saturation is falling down. After release, see the collapse. Now the lateral collapse is very prominent as well as the anteroposterior collapse is also very prominent. So we have to do all the procedure during our DISE, then only we able to judge actually which procedure and which device is definitely going to help the patient. How to interpret a DISE? So this is a slide. So do a DISE for at least 20 minutes. Then patient does not respond to verbal stimuli, which signal is 70 and 50. Introduce endoscope, begin your observation. Observe the soft palate. So start from nose. So go little bit behind, observe the nasopharynx and observe the soft palate, tongue base, epiglottis and palate still open. Observe upper airway just below the choana and see the palate and how it closes. Scope is advanced downward to observe the rest of the upper airway. Observe every level carefully, proceed for maneuver. So this is a slide, very important slide. So what we are doing DISE is that. So observe areas of vibration and collapse. Only the palatal flutter is not a obstruction actually. The palatal flutters normally every primary snorers do a palatal flutters only produce sound. It is not obstruction. Observe the shape of the collapse. So whether it's anteroposterior or lateral or a circumferential collapse. So all we have to observe during our DISE. Then interpret it with your colleagues as well as your senior guys as well as the patient as well as the attender. Then coming into the interpretation, there's a lot of grading systems are available. So word system, normally what we use regularly is a word system, is a velum, oropharynx, tongue and epiglottis. Then NOHL is, they included the nose also. And the palate, tongue base and it's a turbinate and tongue base and epiglottis system, ABC, these all the systems are available. A lot of grading systems are available. So normally what we use the old classification, velum, oropharynx, tongue base and epiglottis. Degree of obstruction is actually 0, 1 and 2, anteroposterior, lateral or circumferential collapse. So all this classification, all talks about this thing. This is my own classification I introduced recently. So I observed the nose. So I divided into anterior and posterior. Anterior is septum and turbinate. It's a static obstruction. Posterior nasopharynx is static by adenoid. Then it's dynamic by the solfaingopharyngeal fold. Solfaingopharyngeal fold normally what we miss in the diagonal slip endoscopy. So it also plays an important role in obstructive sleep apnea. And palate I divided into two, upper retropalate and lower retropalate. Upper retropalate, all three comes into the line. This anterior posterior collapse is by the only saw palate, vibrant part of the saw palate. Then a solfaingopharyngeal fold from the lateral, both cause circumferential collapse even in the upper retropalatal level also. Then lower retropalatal level only by this saw palate, tonsil and both. So saw palate can cause lower saw palate and the tonsil and both can cause so collapse in the lower retropalatal level. Then tongue, the high tongue base is the muscle itself. Tongue base, lot of fat deposition as well as the huge muscle can cause a high tongue base collapse. Low tongue base by the lingual tonsil as well as a lot of lymphoid follicle deposit over the lower tongue base can cause collapse. Then come primary epiglottis collapse. The epiglottis itself is a flappy or C-shape or U-shape can cause collapse at the primary level. The secondary lingual tonsil, sometimes actually huge lymphoid follicle can push the epiglottis back and cause collapse in the lower epiglottis level. So this is my own classification. This is another video. I don't know why the sound is not coming, but anyway. So already he started snoring. It's a very small and fiber optic endoscope. So this is a huge solfaingopharyngeal fold. See, this is a solfaingopharyngeal fold in the nasopharynx cause obstruction. So we divided the grading of solfaingopharyngeal fold 0, 1 and 2. 0 is actually less than 25% obstruction. So itself causing collapse at the level of nasopharynx itself. Since we goes below, we are able to see the saw palate over here. So then go a little bit below and base the tongue base. The saturation is only 68. The huge tonsil causing obstruction level. Epiglottis, this is the lymphoid follicle over there. In this patient is a lateral collapse at the saw palate level, oropharyngeal level, causing the both tonsils are collapsing the oropharyngeal level, as well as the nasopharynx, the solfaingopharyngeal fold causing obstruction. So we have to give a little time in this area to assess the epiglottis collapse. Epiglottis in the deeper sedation, it may behave very differently. Sometimes it may fall back and causing complete collapse. Sometimes, so these two tonsil can compress the epiglottis in midline and causing collapse. We go to assess all. So little time to perform this thing. To improve this thing, we put a jaw thrust, we are able to achieve good anteroposterior. Only the tonsil collapse is there. Sometimes even the collapse may disappear. It's a pediatric DISE. It's an 8-year-old female child. It's a labored breathing. So we did a DISE. Actually, there's a huge adenoid. When we pass behind that, we are able to find the tonsils also causing collapse. As well as the case of laryngomalacia. See the epiglottis, the U-shape epiglottis, and very short AV fold actually, ariepiglottic fold. The tonsil causing obstruction. That's a baby, is a 1-year-old baby. The next, this thing. So once we give a jaw thrust, we are able to improve the airway. So for this patient, I did the AE fold. So give a jaw thrust, we are able to identify the short AE fold. We cut the AE fold, definitely they do better. This is a 1-year-old child actually with a severe sleep apnea. So it's obstructed breathing. The pediatrician referred to us, so to assess the airway. So there's a little bit adenoid. It's a not very severe grade. A huge tonsils actually. As well as this patient, the airway is very good. See the larynx of this 1-year-old child as well as the 8-year-old child. This larynx is a very good larynx. Only the tonsil adenoid causing collapse. So all we need to do a proper DISE to assess the level of collapse and the pattern of collapse. So this is a solving a pharyngeal fold, this thing. Once we do a DISE, concentrate a little bit in the nasopharynx. See, in this patient, a complete collapse in the level of nasopharynx. See the huge folds. So, folds causing complete obstruction. This patient also causing complete obstruction. It's a long segment and solving pharyngeal fold collapse starts from the nasopharynx and goes at the level of oropharynx also. So, give a little bit concentration in nasopharynx, definitely we can achieve a good result in our results. It's a only flutter. In this patient, they do better with a simple palatoplasty. This patient, there's another finding. What we are seeing is a huge tongue base. So you see the tongue base itself. This is a muscular tongue causing collapse at the level of tongue base. It's a morbid 148 kg patient. So BMI is very high. So we do a drug-induced sleep endoscopy. So it's only solving a pharyngeal fold caused collapse actually. So the velum is okay. So this larynx are okay, epiglottis is okay, tongue base, everything is okay. Only solving a pharyngeal fold causing collapse. What I do is actually, so I do a channeling this thing. So another case of solving pharyngeal hypertrophy as well as huge tonsil and a little bit tongue-based collapse. The important thing is actually assess every part of the upper airway and select your mode of treatment and how much degree reduction is also very important. So the tailor-made surgery, so you have to concentrate nose, huge lymphoid follicle causing obstruction.
So can we wind up a little bit?
Yeah, that's all. It's only 2 slides more.
Thank you.
So, this is very important this thing. It's a normal nasopharynx, very thin individual, severe degree of AHI. There is a palatal flutter, little bit obstruction in the level of the velum. It's a very long uvula. Once it's passed behind that, see the epiglottis collapse. It's a very violent collapse. So the volume is not there, but during at the collapse of sound, the epiglottis is producing is very severe. So to assess the collapse in each level to give a good result actually. So I will skip this. This all we have to do sometime intra-orally also. This one is via the nose and the one is via the oral cavity. See, able to see the huge tongue, the tongue muscle itself causing collapse in the midline. So we, in between the tongue, actually the uvula is vibrating. Indication and contraindication. So not this patients with sleep disorder breathing and performed for simple snorer and OSA patient with the CPAP failure. So contraindication, sometimes pregnancy and allergic to propofol and dexmet. So anesthesia grade 4 contraindications or contraindication for DISE also. At that time we must be very careful. So tips and pitfall for DISE is actually tips is very much the safety already we discussed. If not performed in OT, make sure basic resuscitation equipment must be available readily. Sedation, level of sedation is crucial. BIS monitoring is very important. Propofol should not be injected in bolus. It must be given as a slow in slow perfusion. Manage secretion. Sometimes you need to put a suction tube to suck out the secretion. Sometimes otherwise the aspiration may be the worst complication. Maneuver, you have to do a SMAC maneuver and chin thrust maneuver. Classification grading is also important to assess severity of collapse. The pitfall is actually no grading system is so far particular about DISE. Normally, worldwide, what we are using is a word classification. Represents a small part of the night sleep. Normally, we are not stimulate the REM sleep. REM sleep, lot of collapses occur. So REM sleeps we can't stimulate. So only we are assessing the non-REM part of the sleep. So controversy surrounding DISE is, so already discussed, is not a normal sleep. Depth of sedation may be vary in over sedation, and depth is sedation is very severe. The collapse is more prominent, and collapse actually behave differently. Don't assess that type of collapse. Your sedation must be very thing. There are very grading systems available for documenting the finding. So those poses it another issues. Thank you so much. So for patient listening.
Thank you, sir. I would like to call upon stage Dr. Atul Pore, sir, for his lecture on management of pediatric OSA.
I think I made little bit clear about DISE. If there is any doubt, we can discuss later, not now. Okay, thank you.